I would have done a CT abdomen, and it wasn't done. Okay? So search for it. Or if you don't want to do a CT abdomen and expose the patient to more radiation therapy, do some markers. Right? Tumor markers, at least. Okay? And postpartum, even though it's uncommon, I have seen a lot of embolic amniotic embolism on like 24 hours or at least 72 hours, no more than that, postpartum.
Probably was this C-section or?
Doesn't matter. Even after normal delivery. Okay? So again, please go through the risk factors in your mind and ask the patient or ask the family, ask the virtual triad, okay? So again, I mentioned you already, the possibilities, prolonged immobility, ask the patient about any cancer, have you had any recent chemotherapy? Because they might tell you, yes, I have cancer, but I'm in remission. Still, you have the risk, okay? Doesn't matter how long ago. But if the patient recently had chemotherapy or radiation therapy, that's an insult for the body, okay? And any type of phlebitis or, again, whenever you have a young patient that you don't find any evidence of risk factors, you don't see the fracture, you don't see the surgery, you don't see any major risk factor that provoked this DVT or PE, always run the hypercoagulability panel. Or ask the patient at least, what about your family? Have you seen that this is a pattern in your family? That they get strokes or they get clots in the legs or clots in the lung? And if they tell you, oh yes, my mom, my aunt, you have to do this panel before the patient leaves. As we mentioned, all the risk factors, yes, of course, the age of the patient, because the older the patient, the more they'll feel your injury for the veins and the artery. Having hyperlipidemia that she had is a risk factor as well. But those are minor factors. You know, patients with obesity or patients with autoimmune conditions, even though, again, those are risk factors you cannot just label all. The patient has lupus, and that's the reason why the patient has the APE, okay? If it's a young patient, always rule out hypercoagulability disorder. Again, when you do not have the clear evidence, all right? And again, we know this, that the majority of the clots form at the level of the esophagus, and that's the reason why we do venous doppler of the lower extremities in every patient that has a pulmonary embolism. It's just to see if it came from the legs. That's it, but the treatment is not gonna change. It's exactly the same, okay? Sometimes you don't see the clot, it already has traveled, but sometimes it leaves some inflammatory signs that you're able to see with the ultrasound that actually came from the leg, okay? So again, it's never a clinical diagnosis. You unfortunately have to prove it, but there are certain risk factors that make you think about a possibility of a pulmonary embolism and DVT as well. For example, I had a patient this weekend that the patient only was in the hospital, in the ICU, because the patient had anemia of 5, and it was a rapid response because the patient was without mental status, and when they did the CBC, the patient had 6 of hemoglobin, and they transfused the patient got better, patient had melena, and that's the reason why the patient was admitted. But then after that, patient was ready to be discharged because the hemoglobin was stable, right? They did an EGD, they did colonoscopy, they couldn't find anything, and they were going to do the outpatient camera. But when I actually saw the patient, and I assessed the patient had one arm more edematous than the right. It was actually bleeding. I actually did the venous Doppler on both upper and lower extremities. It was completely negative, but having an asymmetry of the extremities might make you think that the patient has the thromboembolic event, or it could be just a phlebitis. In the case, we took off the IVs that elevated the arm, or compresses, and that's it. That's what we can do. Okay, but if you think about it, you have to rule it out. So signs that the patients might complain for DVT, remember that heaviness, They have cramping on the legs. They have, you see the asymmetry of the extremities. In the past, we used to think about when you press the patient's calf will produce pain. That is not specific anymore. When you do venous doppler of the lower extremities and or the upper extremities, basically what you see is if you have an acute thrombi, it's movable. The thrombi tends to flutter, okay, and it doesn't have any damage at the level of the endothelium that gives you factors that are chronic. Clinical wise, as I told you, the patient complains of heaviness, edema, asymmetry. You could have some fever and some persistent leukocytosis. So every time the patient has low-grade fever and persistent leukocytosis, and you are well covered with antibiotic, and you, for example, think that the patient has pneumonia, you do a chest X-ray and it's completely negative, and you do your entire assessment and the patient doesn't look infected, you must rule out DVTs. Because thromboembolic events produces such an inflammatory reaction that produces leukocytosis and also low-grade fever, okay? So persistent fever and persistent leukocytosis with a broad-spectrum antibiotic coverage, you must rule out thromboembolic events as well, okay? Now, because it's obstructing the veins, I'm not sure if you have looked at yourself when you're standing for a long time that your legs get muddled, okay? That's when you have a little bit of venous insufficiency, or when you're exposed to cold weather, okay, because of major vasoconstriction. That is called phlegmasia ceruleum dominans, okay? It's just a complicated name, all right? But in the patients that have DVT, that also could happen because of the obstruction of the blood flow. So as I told you, if you dorsiflex the leg or you press at the level of the calf, can produce pain, which is the hormone side, but that is not specific anymore. We have seen that patients have DVTs and they don't have hormone side, okay? So in addition to that, as I told you, the edema tends to be non-peeling, but you're not gonna say, oh, because it's peeling, this most likely is phlebitis, or this most likely is related to CHF. You must rule out DVT in the patients that are hospitalized and immobile, okay? So what are you going to do for the patient? First of all, you need to have your baseline CBC, okay? Because you're going to put this patient on anticoagulant, right? And since the most common anticoagulant that you will start the patient before you bridge is heparin or Lovenox, these patients are at risk for heparin-induced thrombocytopenia. You need to know the baseline platelet to see if the fifth day, if the patient hasn't received heparin or Lovenox before, if there's a drop of platelet by 50%, okay? In addition to that, you need to have your baseline coags, PT, PTT, and INR, even though heparin and Lovenox will be only followed by PTT, okay? And what about D-dimer? It's not specific. You have a trauma, you have D-dimer move. You have a surgery, you have a D-dimer move. You have any cancer, you have the D-dimer move. So right now, we just get a cold from a virus and we have a D-dimer move. Because remember, D-dimer is no more than a byproduct of the fibrin formation that is activated the coagulation cascade every time you have the inflammatory cascade being activated as well. So it's not a specific factor. But if you measure D-dimer and it's more than 300, you have to pursue other tests. In this case, venous doppler of the lower extremity, or in the case of pulmonary embolism, CT angiogram, right? If it's less than 300, the likelihood of you having a thromboembolic event is 0. So you don't have to pursue further studies. Okay? So we talked about, if you think, for example, this patient that I thought it was having an upper extremity, left upper extremity DVT, and it was completely negative, the Doppler, you don't have to pursue anything else, right? Now, by guideline and by the answer of your exam and board examination, the most specific diagnostic evaluation is not a venous stop of the lower extremity. It's actually phlebography, okay? But who's gonna inject? Who's gonna inject contrast into a phlebography? Who's gonna inject contrast in a vein to see if the patient has DVT? That's the gold standard examination. What we do more and more in clinical practice is the venous stop of the lower extremity to avoid, more insult to the vein, and in addition to that, injecting contrast to the patient that might have many other comorbidities. Okay.
But do they actually ever do a throat? Like,
I've never seen it, but unfortunately, you have to answer that because that's the gold standard examination.
Right, it'll kill them, but it'll work. You'll be able to confirm.
We never do it because again, if the patient is sick enough to come to the hospital, not all of them, but at least 70% of the patient already have acute kidney injury, right? What would you inject and provoke an insult to the kidney with iodine if you have other non-invasive diagnostic solutions that can prove if the patient has a venous thrombosis, okay? So because of the sensitivity and specificity of the duplex ultrasound is 95%, that's the reason why we select it. Again, it's the most common used, but it's not the gold standard. Okay?
What is the VQ scan?
That's the one that got the ventilation perfusion to the lung.
So again, listen to me. When you suspect, listen, when you suspect that the patient has a thromboembolic event, okay, you have, as you could see, low probability and moderate probability. Let me give you the example of what that means. If we think about DVT, for example, you come to evaluate the patient and you don't see any asymmetry, you don't see any edema, you don't see any warm skin, you don't see that the patient is complaining of pain. The patient is mobile, even though the patient had a surgery, the patient is already mobilizing themselves out of the bed. So the risk for that patient to have a thromboembolic event is less, listen to me, is less, even though the patient has surgery, is less compared to a patient that also had the same surgery, but the patient is immobile in bed, do you understand? And you're able to see at least one of the signs of thrombosis, which could be an asymmetry of the extremity. Do you understand? So if you have a low level of suspiciousness, and that also applies for PE, you have a low level of suspiciousness, you could do a VQ first. And if the VQ is more than 300, is when you do venous Doppler. Do you understand? That's the guideline, okay? Now, we don't do that, we just go straight. But when you have this patient that had the same surgery, that is immobile and has an asymmetric leg, or has persistent fever, your level of suspiciousness is moderate to high. And that's the patient that you do not do a D-dimer, you go straight to the venous Doppler. Do you understand?
Yes.
Now let's put the same case for a patient that you're suspecting a PE. Okay?
Wait a minute. Do you a VQ if you're suspecting a DVT?
No, I didn't say that. Venous Doppler. Low level of suspiciousness, D-dimer. Okay? Now, let's talk about pulmonary embolism. Imagine that you now come, me. I'm 49 years of age, I come to the ER, I have a history of asthma, this is true. I have a history of asthma, and I come to the ER complaining of cough and shortness of breath, and my chest hurt, okay? What level of risk I have to have a PE? No. I'm 49, I'm still menstruating, I'm actually menstruating right now.
Very,
very irregular already, so that means that I'm very closer, okay? I'm not in any contraceptive pill, I have never been, okay? So I'm not in contraceptive pills, I am not having a cancer, I'm not a cancer patient, I don't have any autoimmune disorder, I haven't traveled recently outside the country, well, that was in May, right? So,
You are not immobile.
I'm not immobile, I haven't had a trauma, no fracture. So what is my level of suspiciousness and risk for a PE? Low. D dimer.
less than 300?
Then you do the.
If I'm less than 300,
That's it.
nothing else has to be done.
Negative.
Because even though the D dimer is a sensitive factor, if you remember sensitivity and specificity, sensitive factor but it's non-specific, that means that whoever is negative for a sensitive diagnostic test, you have ruled out completely the disease. Okay? Now, if my D dimer is more than 300, you're already screwed because you already did a D dimer. And that could be just my asthma, but unfortunately, you have to do the CT angiogram. Do you understand? Now, it is not wrong either that my guidelines said even though my D dimer is more than 300, I still believe that your level of suspiciousness and risk are low, you proceed to BQ. But you can have the same question. You can have both choices in the same question. Do you understand? So the question that you might have, you have a low level of suspiciousness, you do a D dimer. And if you are positive more than 300, you proceed to the most specific diagnostic test, which is a CT angiogram, unless contraindicated. Contraindications are iodine or elevated urine creatinine. And in that case, you do BQ. Do you understand?
Yes.
But if I'm at 49 years of age and I have asthma as a past medical history, but in addition to that, I just came back from Spain, traveling 8.5 hours, right? And I come in with shortness of breath and chest pain. What is your level of suspiciousness for PE? High. So you do not do a D dimer. You go straight for a CT angiogram unless contraindicated. And if it is, you do a VQ. Ventilation, perfusion scan. Okay? Just walk up the hallway. Okay? So what you see when you do a venous Doppler, even though you're not going to be tested on this because you're not a tech, basically you see the report, right? So you have no blood flow at the level of an acute thrombi, right? The vein compressibility is decreased, right? But that could be, for example, in elderly patients when they have atherosclerosis as well, the walls of the veins are sclerotic and that's difficult to compress too. So but having the low flow is the most significant, okay? Now for chronic DVT, you're able to see collateral circulation, okay? And in addition to that, the clot is already mature, okay? And you're able to see blood flow around it. So what else can you do? Again, you haven't seen these either, you know. Or you could do magnetic resonance venography, right? So you could do from phlebography to venography through MRI. I've never seen that. But of course, those are more specific diagnostic tests. So what would be your differential diagnosis if a patient complains of a unilateral leg pain? Besides DVT, phlebitis, for example, in the patient that had the left upper extremity edema that had an IV, I ruled out first what's going to kill the patient if that thrombi travels, right? Stroke, PE. But otherwise, seeing an IV, my first differential diagnosis will be phlebitis, which also happens at the level of the lower extremity. The patient is a runner or has, is involved in sport, you can also think about possible tendinitis or rupture of a tendon, right? Now, having a DVT, is that an indication for IVC filter placement?
No.
No.
What is the only indication for
No,
Exactly. Okay? Now, we do a lot in clinical practice. Patients with trauma, they get prophylactic IVC filter placement. And this is a temporary IVC. But you don't know how many complications an IVC filter can produce?
Yeah.
They can rupture the vein. They can actually dislodge and embolize. I've seen that. I've seen one case with that. Okay? So it's not like a very, benign procedure to have it when you do not have any type of any indication. Okay? So that's the reason why the guideline says the only indication is when you have an absolute contraindication for anticoagulation. Now, DVTs itself, not only, of course, the level of recurrency could be high, because once you have a clot in the leg, you already have a damage in that particular vein, and that is endothelial injury. That's a risk factor, one of the risk factors for the racial triad that could recur. If you don't eliminate all the risk factors as well, the patient is immobile or having a sedentary lifestyle, the patient smokes, for example, that produces more risk factors, so the recurrence will be higher, okay? In addition to that, you could imagine that the blood flow for that particular extremity is decreased, and that's going to produce venous insufficiency and varicose veins, right? So that will be another complication. Many patients also complain of pain after the DVT. And that doesn't mean that the patient continues to have a DVT or a thrombi in the leg, but there is a syndrome that is basically well documented that at least 6 to 8 months after the DVT, the patients continue to have pain in that particular extremity. And that confuses the practitioners because the patients tend to come back to the ER constantly for the same initial complaint. And that doesn't mean that we're not going to rule it out again. But we have seen in a lot of research studies that patients that after having a DVT for at least 6 to 8 months, they continue to have pain in that extremity. Yes, the patient comes back, you do again a venous Doppler of the lower extremity, the same clot is there because it's already showing signs of chronicity. You don't have to do anything else, do you understand? But it is described, and you have to have that in mind, yes.
Do you still tell them to come back if they feel the pain, or do you tell them it's normal? What do you tell them when they keep coming back?
You have to tell them, you have to tell them that this is very common, okay? That after the patients have a clot, they could continue having pain for at least 8 months. But of course, if the pain is worse than the initial that they experience, they have to come back. You're not gonna tell the patient, don't come back because that's completely normal. Because after that, Dr. So-and-so told me, right? So that is called post-phlebitic syndrome, okay? And of course, another complication is what we don't want, which is traveling to produce a stroke or to produce the pulmonary emboli, or traveling and producing a mesenteric ischemia that we already have covered, okay? So, treatment, how do you treat DVT? The same exact way that you treat a pulmonary embolism. Once you discover that the patient had a thromboembolic event, heparin, drip, based on whatever protocol you have in the hospital, and I never give a bolus, never. I always try to go away from the bolus because, for example, we had a patient with liver cirrhosis and they gave a bolus and the patient had intracranial bleeding. So, always look at the comorbidities that the patients might have for you to give a bolus, okay? Unless this is a stent.
And Lovenox, remember, 1 milligram per kilo twice a day. And even though we have a lot of direct or indirect thrombin inhibitors, factor 10 inhibitors, the Eliquis, the Pradaxa, etc., or Xarelto, your guideline, and again, have proven for years in research that the best anticoagulant to discharge the patient with is Coumadin. Not only because it's cheaper, but also the patients can measure strictly INR and be in a therapeutic range. The complications for bleedings are less, and if they occur, you do have an antidote that you could contain, right? Vitamin K. Now we give K syndrome.
Rextra is contraindicated in renal failure, right?
The others are not contraindicated, you just have to adjust based on creatinine clearance.
So you can give Lovenox to a patient with renal problems?
The best is heparin, but yes, you can give it. Always, you could adjust based on creatinine clearance, the best is heparin.
But we can use Agatroban in renal failure.
Now, argatroban, talking about argatroban, remember that when the patients have a history of heparin-induced thrombocytopenia, that they cannot receive heparin or Lovenox, the best are not anticoagulants, they're actually antiplatelets. They're factor 3A, 2B, glycoprotein inhibitors, or GP3A, 2B inhibitors. Argatroban, Riopro, you can use as a drip and then transition, okay? So you know about, every time a patient is in the hospital, try to avoid the risk factors, air ambulation, put the patient out of bed, pneumatic compressions, and if the patient is not there for PE or DVT itself, every time the patient has risk factors to produce a thromboembolic event, you have to put the patient on heparin or Lovenox sub-Q for prophylaxis, okay? So again, treatment, the same for PE, heparin or Lovenox. The Lovenox, I need you to remember the dosage, 1 milligram per kilo twice a day. And the heparin drip, well, you can because it's really based on the protocol that you go over, okay? If the patient has a renal failure, always try to adjust based on creatinine clearance. But again, what would be the best anticoagulant for you to answer? Warfarin, which is Coumadin. Others, again, factor 10 inhibitors, direct or indirect, Pradaxa, you have Xarelto and Eliquis. Pradaxa, avoid at all costs. For patients that have renal failure, the rest Xarelto and Eliquis can be given, but they need to be adjusted based on creatinine clearance, even though an extra will be the best. And here are the dosages again. This is for prophylactic, unless you have renal failure, then you go down to 30. Okay? And remember, for therapeutic, it's 1 milligram per kilo twice a day. The best is heparin. But you can also give the patient Lovenox and adjust it based on creatinine clearance. So again, what are the risk factors? What are the low probabilities of having? You have a patient ambulating, you have a minor surgery, you have a young patient, and the moderate to high risk factors, think about the visual triad and you will get them all. Okay? Orthopedics are the highest. Every time you receive a patient from rehab, think about thromboembolic event, even if the symptoms do not match. Okay? Let's see what else. I'm trying to move because I want to cover more real cases. Okay? So we talked about this already. Now again, remember, 3 months the first time, the same with DVT. 6 months the second time, and if you have a third event, for life. Now, these are the risk factors of trauma. You have a surgery patient. Or what about if you have cancer? Are you going to eliminate that? you will be with anticoagulation therapy until you are cancer-free. What about if you have an atrial fibrillation?
No.
You will be on anticoagulant until you reverse that rhythm to normal sinus rhythm. Do you understand? Okay? Now, remember that TPA, for the patients that have DVT, rarely done, okay? You don't go and do thrombolysis on a patient directly, unless it's producing already necrosis, right? That would be completely different. TPA most commonly is given for patients that have a stroke, right? Ischemic stroke, thrombotic strokes. Patients that have SSM elevation, myocardial infarction, when the cardiac cath is not available, right? And the patients that have a pulmonary embolism that have massive PE. You don't give TPA to every PE, all right? Even if it's huge, doesn't matter, okay? The size of the clot does not match the symptoms or complications. You learn that. It doesn't match. I have had patients with a very small clot, and they come with cardiac arrest, and I've had patients with saddle pulmonary embolism walking through the ER for some other symptoms, and it's an incidental finding, okay? Yes. All right? And again, IVC filter, the only indication is an absolute contraindication for anticoagulation. Now, again, as I told you, for DVT, TPA or thrombectomy, only when you actually see that that limb is compromised, that the patient might go into necrosis, okay? Or gangrene. Now, PE, you have exactly the same risk factors. I'm not gonna go through every single one, because the same virtual triad is your level of suspiciousness and exactly the questions that you're gonna ask the patient. So, those are there. These are the hypercoagulability panel that I mentioned before. So every single patient that is young, that there's no trauma, there's no fracture, there's no immobility, there's no contraceptive pill, there's no cancer.
No other reason.
How come do you have a PE? A young patient less than 65 does not deserve to have a PE, okay? So you have to check hypercoagulability panel. Okay? Clinical manifestations. What are the most common symptoms? That could be a question for board. What is the most common symptom for pulmonary embolism?
Shortness of breath.
Chest pain.
Chest pain.
No chest pain, no pleuritic pain, no hemoptysis.
Shortness of breath.
No shortness of breath.
Tachycardia and fever.
No tachycardia and
Confusion.
fever. It's similar to shortness of breath, but it's not shortness of breath. Tachypnea. Tachypnea. So rapid, shallow breathing, okay? So you expect, and the most commonly described in the literature is the triad of hemoptysis, dyspnea, and pleuritic chest pain, but over the past 5 years, again in research, you'll have to mention it, that's the reason why we come up with guidelines. We have seen that 95% of patients come with tachypnea. And we missed that a lot, okay? Can you have a patient with no symptom and having a PE? Okay? No symptom related to a pulmonary embolism and it's an incidental finding, okay? As I said, an elderly patient with altered mental status, that the patient doesn't have chest pain, no shortness of breath, no tachypnea, no tachycardia, no hemoptysis. All right? So, what is a pulmonary infarction? We already talked about massive and submassive PE. What is pulmonary infarction? What is myocardial infarction? What is myocardial infarction?
Injury to the tissue.
Is that thrombotic, right? In the coronaries, producing what? Necrosis to the myocardium. That's exactly what happens in the lung.
So you have a clot in one of the branches of the pulmonary artery, and that particular lung tissue that is supposed to be perfused produces a pulmonary infarction. Now, when you open a CAT scan, this patient didn't have it, that's why I'm not showing it to you, but when you open a CAT scan or a chest x-ray, mind you that this is a chest x-ray, okay? All right? You're not seeing an irregular density that could be pneumonia, for example. What you basically see is that when you open the CAT scan, imagine that this is the pulmonary branches and you have a clot right here, okay? The particular tissue that is perfused does not get any type of irrigation, no blood flow. And you always tend to get like a triangular hyperdensity in the lung tissue. That is not recovered. That's gone. Same as myocardial infarction, that's gone. Yeah, like that. Right. Okay? And in the chest x-ray, you also get, it looks very similar to an atelectatic change. And you might think, oh, this is atelectasis. But then when you do a CAT scan, CT angiogram, and you see a PE and that concave distribution right after, that is not atelectasis, that is not pneumonia, because it coincides with the occlusion. That's a pulmonary infarction. You have to tell the patient, basically that area of the lung is gone. I mean, there's no massive change at that level, so, I mean, it doesn't affect much, just compliance. The same as the echocardiogram that affects the EF, but what are you gonna do? Nothing. That tissue's gone, okay? So those are the major complications, and again, the classification of submassive and massive, that remember massive is patient comes with hemodynamic instability, plus you do an echo and you see that the patient has right ventricular strain, okay? What do I mean by right ventricular strain? You do an echocardiogram, and you have different, I can open an echo on any other patient, because this patient never had it. But when you open an echocardiogram, what are you looking at? First of all, you're looking at the EF, right? What else are you looking at? To see if the patient has any type of diastolic dysfunction, right? And the movement.
You can also measure the pulmonary pressure.
Yes, wait, yes. Hypokinesis or akinesis, that means movement in Latin. So hypo, low movement, no movement, right? So those are the words that you're looking for. Then you're gonna have in the echo describe your right atrium, your right ventricle, right? You have your left atrium, you have your left ventricle, then you have your valves described. I'll open an echo for you. And then you have pressures in every single vessel, right? And the pulmonary pressure is read as end ventricular diastolic pressure, okay? Why? Because it's the pressure at the end of diastole in the right ventricle, right? For the left, but in this case, I'm looking for the right. So the normal pressure should not bypass 15. When you have greater than that, you have pulmonary hypertension, right? So you might guide yourself if you have an echo from this patient before, looking at the pressure in the pulmonary artery, right? From before compared to now, if it's elevated, the patient has an acute pulmonary hypertension produced by the PE. And in addition to that, you're gonna look for the right ventricle to see if you have any dilation. If you have that, that's pulmonary or right ventricular strain. Okay? How do you treat massive PE? TPA, or thrombectomy. I'm not saying you're not gonna give heparin after that. You start the heparin. You have to start the heparin until you bring the cath lab, right, to do thrombectomy or TPA. You can give the TPA yourself if you're in the intensive care unit, if you're working in intensive care unit.
Isn't anticoagulation one of the contraindications for TBA?
But not in the case of this patient.
You have to start. It's the same as, okay, you have a patient with STEMI, okay? And you're not in the facility that has a cardiac cath. You have to start heparin drip and prepare TPA and then transport the patient. Do you understand?
Yeah. Always heparin first.
Alright? So this is what I just told you, basically. Don't expect every single patient to have chest pain, shortness of breath, pleuritic, type of, like the typical signs and symptoms of hemoptysis, because many come in, the majority with tachypnea and also asymptomatic, okay? So this is basically no more than statistics. The majority of the presentations, look, oops, look where is your chest pain.
Down.
Not periodic, not periodic. The periodic is
84% dyspnea, but the most reliable is tachypnea. Because dyspnea could be just subjective. I can tell you, I have shortness of breath. But if you're actually able to objectively measure that in a monitor, that the patient has rapid shallow breathing, even if the patient's sleeping, okay, that is more reliable, okay? The same, sign-wise, you have a patient with tachypnea, it's more common than even having tachycardia, even having an S2. What is S2?
The closure of the.
S2 is the IV.
So the closure of the pulmonary and aorta, right? If you have an inverse split, most likely the patient has pulmonary hypertension, right? But it could be tricuspid regurg, it could be tricuspid stenosis, it could be anything related to the right side valvulopathies as well. So it's not specific for PE, okay? And rails, who else can have rails? CHF patients, patients with any type of infection can leak fluid and have rails. So the one that I want you to concentrate is tachypnea more than anything else, okay? Diaphoresis in many patients when they are on distress, not related even to PE, they can have diaphoresis, all right? And the same, don't always think that patients with a PE or with a stroke or with an MI should have a thrombotic event on the lower extremity, even though the majority of thrombotic events come from the saphenous, okay? So again, as I told you, what are the most reliable exams? When a patient comes with chest pain and shortness of breath, yes, of course, you're gonna rule out acute coronary syndrome and then you do an EKG first and troponins. If you think about a pulmonary condition, I know that the most, or the fastest, because you could do it at the bedside, you're gonna do a chest x-ray, but a normal chest x-ray does not rule out PE, right? A normal chest x-ray does not rule out anything. Because I've seen so many processes in a CAT scan that are not visible in a chest x-ray, okay? So I told you already, when you have a low level of suspiciousness, you could do a D-dimer first. If you don't have the option of any exam, it is not even wrong for you as a practitioner to do a VQ first if you have a low level of suspiciousness. But again, you have a low level of suspiciousness and you do a D-dimer and it's greater than 300, you have to proceed to the most specific, which is the CT angiogram unless contraindicated. You have a low level of suspiciousness and you do a VQ scan and it's intermediate or high probability, you must proceed as well with the CT angiogram unless contraindicated. And we'll talk briefly about VQ. Again, spiral CT angiogram is the most reliable, the gold standard examination for pulmonary embolism, and already told you the value of having an echocardiogram in every patient that has a PE to rule out core pulmonary. What else would you do? Of course, I mean, you could do an ABG, but it's I mean, again, what you're looking for as more reliable will be hypoxia. But again, I have seen patients with PEs without hypoxia. So again, 50% of them do have hypoxia, but not all of them. Set rate will be elevated, it's an inflammatory process, okay? So it's gonna also move the coagulation cascade. What will you do as CBC and an hemoglobin? Remember, shortness of breath, chest pain can be produced by anemia. So anemia can produce all these symptoms, so at least have that as baseline as well to be able to start your anticoagulation therapy. I have seen a lot of patients with hemoglobin of 5, 6 that have a lot of diagnostic tests, and when the CBC comes in, that's what it is, okay? And the rest have been more.
So you, and you do that for BNP.
Let's talk about pro-BNP. What about pro-BNP? What is pro-BNP? Pro-BNP, which is your atrial natriuretic peptide or brain natriuretic peptide, gives you exactly the same value as an S3. That's it. Just a stretching of the ventricle fibers. So it's not CSF, it's only stretching of the ventricular fibers. Can a PE stretch your ventricular fibers?
Yes.
Yeah. So since you have a PE, increasing pressure in the pulmonary artery, producing right ventricular strain, stretching the right ventricular fibers, you can have an S3, you can have a pro-BNP elevated. Can you have troponins elevated
Yes.
when a
Yes.
patient have a PE?
Yes.
Yes.
Because they're hard.
And troponins elevated is another marker for massive or submassive. So again, the best indicator for massive is hemodynamic instability. But if you have a positive echo for right ventricular strain or positive troponins, and you haven't done the echo yet, those are criteria for massive as well. Okay? Do you understand?
For massive and submassive, or just massive.
Okay. Remember, again, let's clarify. Echo positive for right ventricular strain, and now I added the troponins when you don't have the echo. That's only telling you that you have a core pulmonal, right? So when you have that alone, that is submassive. But when you add the hemodynamic instability of the patient, that is massive. All right? So this is what I was telling you, the Western Mark sign or the Hampton palm. Those are indicators that there's hyperperfusion of the pulmonary tissue produced by the clot that can give you basically an opacity in a triangular shape on a chest x-ray, basically like a triangle of hyperperfusion, okay, on the lung. But I have seen so many Bs, and maybe 3% have this, so it's very, very rare to see. Like in this particular patient, yeah, but I mean, you need to be aware, right?
That's true.
For example, remember that if this patient that we had before had an elevation of a hemidiaphragm? Okay, this patient in this picture has it in the left hemidiaphragm. So you have the diaphragm basically up into the lung. That's because it's producing hyperperfusion at that level, right? And the pulmonary trunk is more congested, it's more engorged. So that is due to hyperperfusion. But again, rarely seen, because you can have the majority, 95%, a normal chest x-ray. All right? So, another question for board. What you see in an EKG if you have pulmonary embolism?
That's like a Q wave.
It's like a
Q
S wave.
No,
right?
it's a Q wave or something like that.
No, it's
It's
an
an S, S3.
Dan taught me they forgot. S. I think it's like a Q wave.
It's an S3, is an S3. So basically you have, normally, this is an EKG.
She was the one that found me.
okay? Alright, so this is your P wave, your R, your S, right? And your T wave, right? Normally, I can give you an entire class on EKG, but normally your lead one, remember that if you think about the triangle, right? You have lead one from your right arm to your left, so that's from negative to positive. So lead one always have to be positive, right? So positive means that you don't have an S. Do you understand? Because these are positive waves, and the S will be negative, right? So there's no negativity in lead one, right? Lead two, you come from right to left, right? So lead two is also positive. And lead three, you come, this is negative to positive, you come from positive to positive. So lead three is also positive, right? And then you have your precordial leads, which is V1, 2, 3, 4, 5, 6. So the more you go farther from the left side, the more negative, and the closer you get, more biphasic, right? So you could imagine that V1 is negative, lead 2 is biphasic, 3 biphasic, 4 positive, 5 positive, and 6 is negative. Okay, because it's going away, right? And then you have your AVR, AVF, and AVL, okay? Which AVR is if you have negative to positive and negative to positive, you have here two negatives, right? You know what I'm talking about?
Yes, I'm a little, but this is when the person. Yeah, I know.
So we'll take another class later on.
Oh, thank you.
This AVR is completely negative, right? Then you have AVL, which is the leg, right? Which,
AVF is the.
I'm sorry, left, yes, right, left and F. So AVR, which is negative, negative, AVL, here you have negative to positive and positive to positive. So that means that AVF is completely positive, right? And AVF is basically, yeah, but mostly ground too, so what you look mostly is your lead 1, 2, 3, right? And if you come here,
That was in the, when we did also.
so again, you're not supposed to have, first of all, you have to look at your lead 1 and 3, okay? Those are the most reliables for PE. And you're not supposed to have any negative leads, any negative, right? So if you think about lead 1 or 3, you're not supposed to have first a pathological cube, right? And you're not supposed to have an S at all in lead 1 or 3. Didn't I tell you they were positive?
Yeah.
Okay, this is EKG. Positive, positive, negative, positive. Right? When I say negative,
You're not supposed to have it.
is this, right? When I say biphasic, means that I have both, right? Positive and negatives, right? So, if the lead 1 is completely positive, if I now tell you that I have this in lead 1 or 3, that is abnormal. I have a Q, I have a S, and even more if I have an inverted T. Do you understand? So if I have an S in lead 1, if I have a Q in lead 3, and I have an inverted T in lead 3, most likely, I'm talking about more than 90%, I have a P. What else? What else could be indicative of a PE? Right bundle branch block, a new onset. But for that, you need to know the patient before. You need to have a prior basic baseline EKG to compare.
Can you just repeat the V1 to V5? I know V6 and
Oh, but that's no. I'll tell you on the way. Okay? Otherwise, we'll never finish.